Hello everyone. On behalf of the RACGP faculty of Aboriginal and Torres Strait Islander Health, I would like to welcome you to the new Guidelines Family Abuse and Violence webinar. The presenters of today's webinar are Dr. Elizabeth Libby Hindmarsh and Dr. Annalise Crane. Libby has been working in general practice for over 30 years. In the last 10 years, she has been working in Aboriginal health on Alcott Island in Northern Territory and in an Aboriginal general practice on the outskirts of Sydney. Libby has been a GP supervisor and involved in many aspects of GP education. Since 1992, Libby has worked on projects with the RACGP in the area of family abuse and violence, and is a co-editor with Professor Kelsey Haggerty of the RACGP 4th edition Abuse and Violence, Working with Our Patients in General Practice, and is a chairperson of the RACGP Faculty of Specific Interest, Abuse and Violence in Families Network. And Libby is very much committed to keeping children safe. We are also joined by Dr. Annalise Crane, who is a Gamilaroi woman. Her family stems from the Moree district in New South Wales. Annalise is a GP with special interest in aviation medicine and has completed her medical degree at the University of Notre Dame, Sydney, and was their first Indigenous graduate. Annalise is a Qantas wife and a mother of 3 young children who lives and works in the Sutherland Shire in Sydney and enjoys long walks along the beach, crafting with her kids and baking. And now Dr. Crane will commence the webinar.
Thanks a lot for that, Danielle. I'd just like to kick off with the acknowledgement of country. The RACGP would like to acknowledge the traditional owners of the land where we meet today, and that's all across Australia. I'd like to pay my respects to the elders, past and present, and also to welcome, I can see there's 1 or 2 Aboriginal GPs listening in, and of course to the health workers and other Aboriginal and Torres Strait Islander people listening in today. And Libby and I are here at the North Sydney office on Cammeraygal land. So let's kick off with a bit of a poll. I'd like to get an idea of who's listening in today. So if you can click on the poll as soon as it's launched and let us know, who are you? Are you a GP, a health worker, a practice nurse, practice manager, or someone else exciting listening in today? But let's kick off with the learning outcomes. I'll hand over to you, Libby.
Thanks very much, Annalise, and welcome everybody. Lovely to have you online. So today we hope from this webinar that you'll be able to identify family abuse and violence by case finding and antenatal screening and other preventative interventions that are in the chapter 16.
I'd like to outline the role of GPs, practice nurses, Aboriginal health workers in the context of family abuse and violence and for Aboriginal and Torres Strait Islander people.
And during the webinar, we'll discuss some of the barriers to effective implementation of family abuse and violence support services faced by Aboriginal and Torres Strait Islander communities. And you will note that you've all received a copy of the case, Leah, and we'll refer to her as we go through the webinar.
And if you haven't had a chance to read that case, I'm sure we can send it through again with the follow-up material at the end. And just the last learning outcome is to recognise how the National Guide can support best preventative practice for Aboriginal and Torres Strait Islander people.
So let's have a look and review the chapter. The chapter involves some background information, some identification, some interventions, some recommendations and resources, and we hope you've had a chance to read the chapter and the case. So in the background, the family abuse and violence is the term that we're using in this chapter, and there's lots of other terms that get used like domestic violence, but it's going to cover victims, perpetrators and children.
I think it's a really fascinating statistic that Aboriginal and Torres Strait Islander women are 34 times more likely to be hospitalised due to abuse and violence. And I just note from the case study about my patient Leah, she didn't end up going to hospital. Her first port of call was to actually come and see me, even though she probably should have been in hospital.
And we know that family abuse and violence is the greatest driver for Aboriginal and Torres Strait Islander children being in out-of-home care. And this is of real concern, and we need to rethink how we're managing this. Otherwise, we will have the equivalent of another stolen generation.
I also find it astounding that Aboriginal men who've been to jail and their high rates of incarceration play a large part in family abuse and violence. And I note that from the case, Leah's partner had already been to jail. Yes, in this case it was for drug and driving offences, but he certainly was well acquainted with the courts and the jail system and being on parole. So, you know, I'm sure you're aware of the statistics that Aboriginal people alone are much more likely to go to jail than non-Aboriginal and Torres Strait Islander peoples.
And then the terms used to describe what is happening within the family are often minimised and used to excuse the abuse and violence. So in Kylie Cripps's work, she identified that Aboriginal women often play down what is happening. So they might say, just being cheeky, or we just had a small fight, but we need not to be taken in by this. And we need, as the health professionals, not to dismiss the violence. So let's talk about identifying family abuse and violence. So what we're trying to encourage is early identification and support. And we note in the case of Leah that here the previous abuse at the time of her miscarriages was actually missed. But the very important first aid of family abuse and violence is that we ask and we explore safety.
I think when we continue to look at identifying abuse and violence, we need to consider ourselves as healthcare providers. And I'd also just like to take this opportunity to welcome Andrew, the paediatrician who's listening in at Tharawal, and also Mohammed here's got a registrar and some students, and they're listening in as a group over in Adelaide. So often we're the first point of contact. And whether you're a social worker, whether you're the Aboriginal health worker, whoever comes to you and discloses that violence, I think it's really important to have the right skills and knowledge and know where to get help from for your patients.
So if victims present, then it may be with a range of symptoms. They may not be walking through the door saying, I'm here for family abuse and violence. They're much more likely to be walking into general practice with depression, anxiety, difficulty sleeping, post-traumatic stress disorder, non-specific pain, drug and alcohol, and in a number of other ways. But the underlying issue, however, is family abuse and violence. In Leah's case, it was physical violence and a more obvious presentation.
It's interesting, I was chatting with Libby and saying that although Leah had come in following the physical assault, she'd had numerous presentations for a bit of anxiety, some nausea, some diarrhea, all different non-specific type presentations that, you know, perhaps if she was probed or when she was ready may have disclosed the bigger picture. Most of us listening here are mandatory reporters. So I think it's important to consider children and making sure that we do report to Family and Community Services or your state equivalent if you can't guarantee the safety of the children. In the case of Leah, there was a fact where in New South Wales a fax notification was made by an anonymous reporter, and that sort of triggered a cascade of unannounced home visits and all kinds of safety checks.
So perpetrators are also being seen in AMSs or general practices, and there is an opportunity for us with training, to start to identify these perpetrators. They're mostly going to be men, but sometimes they may be women. And we need to consider how we can make therapeutic interventions available to perpetrators.
I think it's time for us to have another poll. Maybe Sammy can give me a hand to launch that. I just want to ask you all, are you currently doing some screening for family abuse and violence in your antenatal screening? There's no right or wrong answer. I suppose it's just to get a bit of a picture of what everyone's doing. I know in New South Wales, it's the hospital who's often responsible for the booking visit around 14 to 16 weeks, and that's where the extensive screening goes on about domestic violence and what's your partner doing. And I'm just looking at all of those answers coming in now, and it's very much a mixed bag. There's sort of no dominant response at the moment, but we'll just give you a few more seconds. If you're participating in a group, have a chat to your peers and sort of think, what's your workplace doing? And down the track, we might look at how people can do things a little differently.
You know, it's 73%, so we might share those results now so that people online can see as well. There we go.
So as you can see, the results are pretty spread. So we've got sort of 30% of people saying yes, you do screen for abuse and violence at an antenatal visit. About 40% don't yet, and then the rest, another 30%, are sort of thinking about it. So I suppose part of us listening here today is because we're more interested and would like to learn more about family abuse and violence. And certainly from my experiences with the patient Leah, I've considered sort of incorporating it into whenever women present for a miscarriage, or perhaps at the time of their cervical screening test, looking at how I can incorporate it more into my general women's screening, but certainly earlier in antenatal care. So we're going to move on to the interventions part. I think the first point is to ask. We really need to ask women, and then if they do disclose, yes, I am subjected to physical, emotional, or different forms of violence, how can we develop a safety plan, and how can we help them, and what management strategies can we then put in place? And I think it's really important to look at our management as chronic disease management, looking at this patient long term, chipping away at little bits and pieces, making small gains, seeing the patient regularly, involving a multidisciplinary team in their care.
And in terms of interventions, we're only part of what should be going on in terms of managing family abuse and violence in the whole community. So if you have the opportunity to involve your community, maybe in having a community committee looking at this issue, involving the legal services, involving the police and other services that are provided within your community.
Then we're sort of going to look at some of the barriers, and they've certainly been identified in the case study about Leah. I think the just little things that I thought about for barriers in general is looking at transport. Can the woman get to appointments? If the partner happens to own the car and now there's no car, how does she get around to things? Attendance at appointments due to other family responsibilities, whether that's she's got other children or grandparents to help care for, financial considerations, and past experiences. Has the patient had any previous contact with the legal system or the mental health system or drug and alcohol system that might sort of scare them or steer them away from the service, or are they just embarrassed and shamed about having to have these conversations and engage with their GP? Or perhaps if you're in an AMS, health workers, they're concerned about the gossip and information being spread around and lack of confidentiality.
So we've talked about screening, so we won't talk about that anymore now.
And then case finding as well. You know, I'm sure you all understand that case finding is more about if you perhaps see someone come in with a physical injury, asking more about it. If you observe the partner to be inappropriate, perhaps in the case of Les, on one of her pregnancy consultations, the partner turned up stoned to the appointment and didn't look at me the whole consultation, wouldn't answer any questions. And, you know, hindsight's a wonderful thing. So I think we're going to move on to the third and final poll. And I've certainly noticed from some of the questions that we do have a few rural people listening in. So click away and let us know where are you. And we will get an opportunity to answer most of your questions. And Claire, I think it's really important to look at mandatory reporting, particularly if you're in a small town, particularly if that couple or partner perhaps attends the daycare or the school where your children also go. It's going to make canteen duty and things like that very difficult.
So about 30% of you are in the city, some of you are in the outer urban area, 29% are rural and 5% are remote. So your place of practice will influence what resources are available to you. There are likely to be more resources in the city, but more possibility of community involvement in rural and remote. So thank you very much for letting us know about that. So we're just going to go through the recommendations. So they're screening, behavioural and environmental.
Libby, maybe we could just talk a bit about mandatory reporting for our rural and remote listeners and how it sort of puts you into a difficult situation.
Well, it can, but it also can be the very thing that provides safety for the children. So some of the behavioural things we'd like you to think about are to consider who's at high risk, and that's the younger women and those with a history of substance abuse, marital difficulties and economic hardship. So we want to think about how perpetrators can be engaged. We want to, if we can address drug and alcohol use in patients and families, as you'll see some of the information in Chapter 1 and Chapter 4, if we can reduce that, we will reduce the risks of some of the family abuse and violence. And we all need, as healthcare providers, training and support to address it.
So it looks like everyone can now see the screening and case finding. Just to sort of get a bit more into the what can you do and how can you be a bit more helpful. Looking at some of the behavioural and environmental factors there, I think it's really important to start early, particularly with school-based programs through the PDHPE curriculum, looking at healthy relationships and, you know, even those programs even start in early childhood centres. Really, from a community perspective, looking at support groups for women, different emergency shelters, and these certainly have been successful in a lot of the rural and remote Aboriginal communities. You know, Halls Creek is one that I've worked in before, and these services seem to have worked quite well. They may not be working well currently, but at times they have worked. Looking at how to get appropriate legal care, and, you know, you as a GP being able to say, have you contacted the Women's Legal Service? Have you contacted the Aboriginal Legal Service? Have you contacted Legal Aid? And again, alcohol and drug use is implicated in a lot of family abuse and violence. So looking at harm minimisation strategies from a sort of larger perspective as well.
So some of the resources are the chapter that we've sent you, the 16 from the Preventative Health Assessment for Aboriginal and Torres Strait Islander people, the 3rd edition, and remember the National Family Violence Prevention Legal Services. I hope you've heard about 1800 RESPECT, which is the national phone line that patients can ring, but also you can ring that as a health provider, whoever you are, to get information and support yourself. And then, of course, there's the RACGP White Book with specific chapters like 5 on perpetrators, 6 on child abuse, and 11 on Aboriginal and Torres Strait Islander communities. And look at the case study of Leah. That might be a very good case study for you to discuss as an AMS or as a practice.
I'll just read one of these questions, Libby, and maybe you could answer that yourself.
I've got a question that inquires about learning some specific skills on how to ask screening questions, what to ask,
Yes.
how to respond to disclosure, and what actions to take.
Well, the first thing to ask about is to ask about how are things happening at home, what's happening at home and how are things. And very often people will sort of say, oh, they're okay. But it's worth going on to ask then some slightly more specific questions, such as, are you ever frightened of your partner? Has there ever been any violence in your relationship? Sometimes when people come in with these symptoms, as we discussed before, depression and problems with sleeping and things, you can say, I've had other patients who presented with this, and sometimes there's been some sort of family abuse and violence going on. Has that ever happened to you?
There's a really good question here that's just come through. I'd just like to, I'll read that one out, and thank you. I think the person posting the question's in the Shoalhaven region. I'll stand corrected if I'm wrong. He would like to hear our strategies for managing the community, elders, extended family of a sufferer of domestic violence in an Aboriginal and Torres Strait Islander population. I think it's a really good question, particularly with confidentiality, particularly if the perpetrator is a highly respected or elder in the community, how we manage that. And I think some of the remote communities have done this really successfully. And it's difficult when you don't have a lot of options about where you go to access healthcare or police care or legal care, and that's when it poses a problem. Libby, have you got anything to say there?
Well, I think that the primary person you're dealing with is the victim, and you need to be working with the victim to work out what they feel comfortable doing. And you do need to maintain confidentiality, but then you can work with your patient around what they think is going to be helpful, what is going to help to keep them safe, and what their needs are. But on a community level, to be getting the community to look at what is going on in their community, to work out strategies that could help, and to then start to be doing some things within the community. Some of those will be maybe identifying where there are problems. Some of them may be working on reducing the amount of drug and alcohol that's happening within the community. And some of them will be about helping people within the community to heal from the multiple traumas that have happened to them.
I think a lot of strategies that have had some good success in the past are looking at men's group and men's healing groups. In the Illawarra Shoalhaven region, there's a Aboriginal health worker who was studying medicine who actually started up a running group and a cycling group and directed a lot of the angry men into fitness and exercise. And I'm unsure of the statistics about it, but it certainly got those men empowered into doing different activities other than being at home where they may have been drinking and involved in abuse and violence. I think it's really hard in smaller communities. Perhaps our GP colleague from Tasmania may be able to shed some insight into this as well. When you're working in a much smaller community, how you go as sort of controlling the situation and not compromising your own professional integrity when you're dealing with these situations. I think in cases like this, being able to accept outside support, perhaps from telehealth services, perhaps a psychologist from a telehealth service, or a psychiatrist, bringing in outside people to sort of diffuse the situation a little bit may be helpful. And even ourselves sort of looking at peer support, debriefing and offloading for ourselves, but of course still following guidelines and working really well together with the community. So the case of Leah at the moment, we've been having family case conferences that have been managed by New South Wales Health, where there've been social workers, DV support officer, the midwife, the GP, a family contact person and the patient herself, and we've had some shared decision making. I believe that the police weren't involved in that scenario, so perhaps in the future it would be good to involve a police support person as well. But you know, in other communities, looking at including housing, mental health workers and other specific services linked to the problem that you've got in your community. And there's just another question there. How do you tackle, hang on, there's a new one coming along. How do you tackle a situation where the partner is attending the consult and seems to be answering all the questions? I would approach this in the same way you do when you've got the mother of a 14-year-old answering all the questions. Politely ask them to leave and use one of those inclusive statements as we like to interview all of the patients separately, and then there'll be an opportunity to see that patient, see both of you together. And that's, I think, something that the midwives at the hospital do really well. They say, okay, now we're going to ask the women some questions. Could you please step outside? And I think it's a massive red flag if they refuse to. And as someone else has sort of commented there as well, you know, rescheduling and continuing to follow up the patient, you know, seeking it as a chronic care case. Okay, let's see you in 2 weeks, let's see you in 2 days, depending on how things are going. Have you got anything to add there, Libby?
No, but GPs do talk about how difficult that is, and that how some of the perpetrators who attend are very difficult to get them to leave, and sometimes that they have said that the patient needs to have some blood tests or they need to have some other things done, and have taken the victim to the practice nurse and had to separate them in that sort of way. It can be very difficult. Yep.
This is a really fascinating question, and it's certainly not something that I've considered before. If the perpetrator presents to his GP reporting that he had been involved in violence against his wife, how would the GP deal with this in regards to mandatory reporting? So you've got, you know, Mr. Joe Bloggs has turned up and said, last night I hit Mary. How do you manage it? And I think looking at listening to the patient's concerns, trying to get an understanding of the story, assessing safety, you know, are there children involved in the equation? Are there weapons in the house? Are they on a farm with access to lethal means, or are they isolated where there's difficulty to seek help? I think on the occasions where you do, like, use the scenario of you've got an acutely psychotic patient that comes into the room, you have the conversation with them, I'm going to ring this service because I'm worried about you and I would like to get you some help. That would sort of be how I approach it. I understand that you were frustrated or angry and perhaps that's why you hit your wife. But you know, you've come to me, therefore that, to me, that's a sign of wanting help. So therefore, let's get you some help. Let's engage you with a psychologist, engage you with some anger management programs, engage you into the men's group.
Behavioural.
And I think it's important to, maybe I'm wrong, but I often don't jump on the hotline and report people there and then in front of me. I certainly don't take that approach, but I think it certainly depends on the level of violence and what the situation has been. What do you think, Libby?
Well, if you're in the Northern Territory, you are required to mandatory report if the adults in the of the abuse. In all the other states, you're only required to report the children. In this case, if he's come and said he's hit his wife, you at this point in time don't know what's happening to the children. If you find out during that consultation that you really think the children are at risk, yes, you might consider then that you have an obligation to mandatory report. But at the point in time where he comes and starts to tell you about this, unless you're in the Northern Territory, you don't have a requirement to mandatory report. It takes a while if the victim comes or the perpetrator comes to know what's going on with children, but it is really important. The time that you would actually report it to the police is if there'd been a gun or a knife involved in the attack upon the victim. We consider a reportable rather than a mandatory reporting. And the police suggest that we should be asking people, is there access? Not only is there a gun, of course there is always knives within a household. Is there a gun within the household, or does the perpetrator have access to guns or other weapons?
There's another excellent question here from someone in New South Wales, and I absolutely agree with what she's saying. She strongly suspects that patients are not disclosing for fear of having their children taken into care. There's limited crisis accommodation, and it's often, you know, away from their school and daycare environment or too close to where the perpetrator is, and not a lot of rehousing options, and certainly accessing Aboriginal housing and attending housing meetings is stressful and frustrating. Do we have any input on how best to sort of support this and facilitate disclosure of the violence in order to keep the families together?
Well, we may not be able to keep the families together, especially where there's a lot of violence going on, because you can't maintain the safety of the victim and the children within that situation. So that it becomes essential that the victim and the children are able to go to a place that is safe. And that may be to a safe house, it may be to relatives, it may be to friends, or it may be that they need to go to a refuge. But I think the important thing is to be focusing on the victim and the children's safety.
I'm not sure if this is still the case, but my sort of exposure as a patient in an Aboriginal medical service, the AMS had access to funding and support to be able to organise crisis accommodation. So they'd be like, okay, we have a budget for 1 week or 10 days accommodation. So if you're in mainstream general practice, perhaps it's worth contacting the local AMS and either speaking to the GP on duty or the health worker or the social worker or even reception staff and looking at, you know, we have an Aboriginal and Torres Strait Islander woman here with us now. Do you have access to any funding or services, or whether it's food, transport and accommodation, and perhaps redirecting the patient to the AMS may work. Alternatively, in the case of Leah, the hospital social worker and midwife were the ones that sort of had the access to all of the funding and the service. And in her case, that was to do parenting classes, additional childcare, a safety phone, extra security at the house. And, you know, they're all things to me as a mainstream GP that, of course, I was oblivious to the fact that these style of things were funded. We've probably got time for 3 or 4 more questions. If anyone else has got anything that they'd like to write in, I'm just going to read out one more that we've got here. Regarding the signs and symptoms, is there any difference between the Aboriginal family abuse and violence and non-Aboriginal family abuse and violence?
Well, we know that with Aboriginal and Torres Strait Islander abuse, there is a much higher level of physical violence and more likely for them to be hospitalised. So we know that that's an issue.
I think we just lost our audio connection for a moment there, so I hope you could hear Libby's answer coming through there. But
well, I'll say it again if you like, just in case you lost it, that we know that with Aboriginal and Torres Strait Islander victims, that there is a higher chance of physical violence and a higher chance of hospitalisation. But the other things that we've talked about also apply to this group of people.
In the case with Leah, the partner had for a long time punched her in the back of the head, and he had actually said to her, the reason I punch you in the back of the head is because no one can see it, so I can get away with doing this. And it was only on the one occasion that he had attempted to strangle her and break her nose that the injuries became visible and therefore brought to our attention.
So we just need to say too that strangulation is a sign that things are getting very desperate. So if you're talking to people about what's happened to them and they've been strangled or hit about the head, then in fact they may have an acquired brain injury from the lack of oxygen and also from the trauma. So that's an important aspect of those things that needs to be considered. And it may mean that the woman has problems remembering, is, you know, feeling confused, has trouble with memory, has headaches. Yep. So that's an important thing to be considering.
I think we've covered all the questions, and I apologise if we haven't, because we've sort of got 150 people on a chat view. That's just a little bit difficult for me to sort of scroll through and check that I've covered everything. So are there any further questions or comments from everyone listening in? Libby, I think we could satisfactorily sort of finish up there. And yes, I'm sorry we finished a little bit early. You will get copies of the slides and copies of the case study as well. And some people said they were after more specific information about how to ask the questions. I think similar to if you take a sexual history or you're taking a mental health history, it all comes with practice, and looking for feedback from your patients is really important as well. Looking at making sure you've established a good rapport with the women and the children that you're working with, so that they know they can trust you and return to see you.
And if you are looking for some more information about specifically how to ask and things, you'll find it in the first 3 chapters of the White Book, and you'll find there the questions that Kelsey Hegarty established through her PhD were the sort of questions that are likely to be helpful in getting people to be able to talk about their abuse. So there are a lot of barriers to people being able to do that, and for some people they're also at the stage where they haven't actually acknowledged that what's happening to them is abusive. They think that the only abuse is physical abuse, and they don't recognise the emotional, psychological, financial, social isolation and things that are happening to them as being part of the abuse. And you may be able to help them to come to see that this is not acceptable behaviour.
So just once again, thank you to everyone who's logged on at lunch today. We're sorry again about the IT issues that we've been having, but I hope you've taken something away from this, and even if it's a chance to read the case and the slides when you have 5 seconds in your life. But Libby and I will sign off for you now. Thanks again, everyone.